into the VA, Harborview, and WWAMI regions. I understand part of it's Alaska. Please invite me up there. I've never been there. And maybe we'll talk about Barrett's. So a couple years ago, when I first got here, I spoke to you all about colon cancer screening in my work, understanding why patients don't get screened. This is kind of the second half of my research program. And I'm going to present to you some of the work that I've done, also some of the work that my mentees have done, but really try to focus on what's going on with Barrett's esophagus. And hopefully we can answer some of these following questions. What are the current recommendations regarding screening and surveillance and new therapies? Probably the biggest questions we want to ask, are we screening the right people? Is it all heartburn? I think everybody here should understand that Barrett's, of course, is important mainly because it's a precursor for cancer. And we identify people for Barrett's screening mainly by symptoms of heartburn. And the last thing I'm going to ask is now that we have endoscopic therapy, is it actually the cure? And so this is Barrett's. Technically it's called the proximal displacement of the squamocolumnar junction. All that really means is that you get some red stuff here and some gray stuff here, and that should be all gray. And if you biopsy the red stuff, it looks like this. Instead of squamous tissue, it's specialized intestinal metaplasia. So it has goblet cells. And so these are normal tissue for the small intestine, but again, abnormal location. So not neoplastic, it's metaplastic. But we believe this is the one precursor for esophageal adenocarcinoma. And almost all, if not all, esophageal adenocarcinoma is believed to come from this particular lesion. There's some speculation that perhaps even gastric metaplasia can give rise to cancer, but we can talk about that in discussion. The reason this is important is not Barrett's itself, but because, of course, it's related to esophageal adenocarcinoma. And this is a time trend of the incidence of esophageal adenocarcinoma in the US. And you can see basically that it's been steadily increasing. In fact, it's one of the few increasing cancers in developed countries. And there's some discussion about, gosh, this is kind of tailing off right here, but and I'll show you some of the data later on. We've got data that show that, no, it's not tailing off, it's continuing to increase. And the question is why? And hopefully we can answer that today. So one of the problems about what we're doing with Barrett's is we kind of let the horse out of the barn. And too early, I would say. And the issue was that we started developing strategies to try to screen for Barrett's and try to reduce cancer risk kind of before we understood what to do with it. And one of the things that we didn't do a very good job is understand what the real risk of cancer was. This is a funnel plot. And for those of you who don't see these things normally, this is on the x-axis is the cancer risk, higher cancer risk out here. This is actually 3% annual risk, 2% annual risk, 1% annual risk. And these are just in 1,000 patient years. And on the y-axis every dot is a study. And the y-axis just says how many life years or patient years are in that study. So usually what happens is that when a new entity is described, you're going to have a bunch of little studies, and they're going to have widely varied estimates of whatever this is. In this case, it's a cancer risk. And over time, you're going to accumulate more and more patients and trials, and then after a while, you're going to get some better estimate. And this particular estimate, this is 12 years ago, was that the original idea about the cancer risk was really overstated. It wasn't a 3% or 2% annual cancer risk. It was more like here, which is a 0.5% annual risk of cancer. The other thing that comes up, this is a funnel plot, and a funnel should have two sides to it. And you can see here that while there's a good side on this side, a lot of little studies showing high cancer risk, there's a real paucity of smaller studies showing small cancer risk. So this was indicative of publication bias, meaning that either people who had cohorts with low cancer risk weren't submitting these publications, or if they were, they weren't getting published. That's publication bias. So a couple of interesting things about this. So there, 12 years ago, we thought, well, maybe it's about 0.5% per year annual risk. And then, well, gosh, still Barrett's is still pretty prevalent. Maybe we should still worry about this. So the interesting thing is that a lot's gone on in the past 10 years. Now this particular risk may not actually be 0.5%. It may be as low as 0.12%. This is actually from a Danish study by V. Jensen. And a couple of things were very interesting. That this was what caused the splash in New England Journal last year. Gosh, you know, maybe this is a cancer risk that's, I keep bumping this thing, sorry, much lower than we thought, much lower than we thought that was really low. And the second thing is this, is that, again, this is a risk among patients who are diagnosed and followed with Barrett's, mainly through surveillance, 0.12%. The other thing that kind of got buried in the results in two little sentences basically said the following. There's about 2,600 patients in that little country who had esophageal adenocarcinoma, and less than 200 of them were identified through surveillance. And there was only 92% of the cancers, esophageal adenocarcinomas, developed in patients who had not been previously identified with Barrett's. So even though there's a nationwide program to screen the Danish population, it really appeared that they were getting it wrong. In fact, there's a lot of interest right now in trying to understand who we're screening. And one of the things is asymptomatic Barrett's, meaning Barrett's, patients with Barrett's who don't have heartburn, are they the high-risk group? Because it's pretty clear that what we're doing right now, which is screening patients with heartburn to identify with patients with Barrett's, once we do that, that's actually a low-risk group. These are the data right here. So I'll talk a little bit more about that, but this is something that, again, is some empiric data that were presented last year. So let's talk about that. Who are we screening, and is this the right group? I'm going to show you some data from Joel Rubinstein. Joel was a fellow of mine at Michigan. Now he's a faculty member. I keep saying junior, but he's actually up for promotion, so I'm feeling my age. And so this is work that he and I had done over the number of years. And this is actually a plot, a little bit busy, and I hope you can see it. Oh, you can. And the pinkish lines are women, and the bluish lines, they're men. And the interesting thing is that the highest line is breast cancer risk in women. This actually is, this is actually the colon cancer risk in men. And this is men with daily GERD symptoms. And if you look at that risk of esophageal adenocarcinoma, it's right here. So even among men with daily reflux symptoms, which of course is what we think is a high risk for esophageal adenocarcinoma, their risk of colon cancer is still 4 times higher. And so whenever I ask a patient who's been referred for GERD screening or for screening for Barrett's, I say, well, we're not going to do an EGD looking for Barrett's until you have your colonoscopy. And they say, damn, it's that prep again. But yeah, that's an interesting thing. The second thing that I think was also very interesting is the very bottom here. Right here, almost superimposed, is the risk of esophageal adenocarcinoma in women. Basically, this is similar to the risk of breast cancer in men. And of course, we don't screen for breast cancer in men. Now, of course, this gives rise to maybe we shouldn't be screening for Barrett's in women. But there's always caveats, and I'll show you a video in a little bit, and in fact, it's in a woman. So these are the issues. And the issues really are, gosh, can we predict who actually can develop cancer? We use right now dysplasia, which is obviously a morphologic, histologic diagnosis. And there is some prediction. If you look at patients who've been diagnosed with Barrett's by biopsy, among patients who don't have any kind of dysplasia at the initial biopsy versus those with low-grade or high-grade dysplasia, you can see that this is not a meta-analysis. This is kind of compilation of studies. You can see that there's a progression. Obviously, people who have baseline dysplasia have a higher risk of cancer subsequently. But it's a really incomplete, and it's a very tarnished gold standard, if that. And certainly we have to have better ways of doing this. Now, I told you I'm going to tell you what we're recommending doing. And so here are a couple of guidelines. The first is the American Journal of Gastroenterology, the American College of Gastroenterology. This was done about 4 years ago. And that particular guideline recommended screening white men over the age of 50 who had GERD symptoms. And then you do surveillance. Surveillance means once you identify a supposedly high-risk group, you do a bunch of stuff in them. In this case, endoscopy every so often with a bunch of biopsies, looking mainly for dysplasia or cancer. And if you don't have dysplasia on 2 exams spaced a year apart, then the interval for surveillance is extended to 3 years, low grade every 6 months, and then you can kick it out to 12 months. And then for high-grade dysplasia, at least 4 years ago, we talked about either doing surveillance intervention using EMR, which is endoscopic mucosal resection, PDT, which is photodynamic therapy, or RF, which is radiofrequency ablation. Surgery was also an option, for groups that had centers with a lot of volume, but usually surgery is reserved for patients with cancer. I was part of a group of the AGA, and I'll show you some of our recommendations that we made last year. And we're trying to get away from this idea about just GERD. And in fact, we hedged a bit because we said multiple risk factors without giving anybody idea of how many multiple means before we trigger screening. So I have to apologize about that. But the risk factors are age greater than 50, male sex, white race, GERD symptoms, but also hiatal hernia and obesity. You know, of course, the problem with hiatal hernia is you don't know you have it usually until you do endoscopy or CT or something. But the other parts are certainly demographics that we can get by exam. But certainly the idea here is that if you have other risk, such as obesity, age, and race, perhaps you don't have to have reflux symptoms in order to be screened. And very similar kinds of recommendations. Other than I can just show you that we no longer recommend surveillance. I think at this point, if you have high-grade dysplasia, you got to do something about it. And we'll talk more about that. Well, gosh, does surveillance work? We can say yes. There's a variety of cohort studies. In fact, one of them I'm going to point out is done by Dave Carney. This is actually 10 years ago, but Dave Carney, of course, is one of our faculty members at the VA. And these are studies of patients with adenocarcinoma of the esophagus and cardiac. Cardiac, the problem is you can't actually distinguish either histologically or even by most codes. So we add those in. And if you look at patients, and this is not a meta-analysis either, so I apologize, but if you look at patients who have undergone surveillance, meaning had prior endoscopies, compared to patients who did not have prior endoscopy, it appears that surveillance works. There are 5-year survival of 80% among patients who had prior endoscopy and only 20% among patients who weren't surveyed. Well, maybe not. And why is that? Well, there aren't any randomized controlled trials. You can imagine it would be difficult to randomize people to no surveillance versus surveillance. But also, these are very small cohort studies. If you look at the kind of the entire world's literature, less than 50 patients in these surveillance tracks who really are upon which we're basing all these estimates. But again, the problem is that once we're identified with Barrett, it seems like this is a very low-risk group. Now, there's a variety of reasons why it may not work, and these studies may be wrong, because there's always a bias. One of the obvious ones is that the potential bias of comorbid disease. You know, obviously, if you're sick, you tend not to get surveillance, and if you're sick, you tend to die. So maybe they're unrelated. There's also the possibility of lead or length time bias. So the bottom line is that earlier diagnosis may not equal longer survival. And I'll tell you, this is a study that we kind of try to illustrate this. This is another study that Joel and I did. This is, we wanted to answer the question, does surveillance endoscopy improve survival among GERD patients who develop cancer? So same thing. We actually used the VA national database, took only patients with esophageal adenocarcinoma who had a prior diagnosis of GERD, had been seen in the VA, so we could tell whether they actually had surveillance previous to the diagnosis, accessed their cancer, looked at their exposure for endoscopy, and had a variety of outcomes. And the bottom line is this. If you look out to 5 years, which is basically the amount of time that the prior studies have looked, it does appear that compared to patients who didn't get prior endoscopy, those patients who had prior endoscopy did have an increase in their survival. But if you take it out to 10 years, this goes away. And the issue was, well, gosh, if long-term survival is no different, but you have this blip, most likely the blip where, in fact, most of the studies focus their analyses, perhaps there's bias. And there's two types of bias. Lead time, I think everybody knows. The typical thing is like, gosh, if you have twins, they're born at the same time. Let's say cancer develops them both at the same time. They die both at the same time. One of these twins, you don't do screening. You just do diagnosis when they get symptoms, and they have a certain survival time. If you screen before they have symptoms, you know they have cancer, but they die at the same time. But the apparent survival time is longer. The observed survival time is longer. That's just lead time bias. What you may not know more about is length time bias. And length time bias assumes that there's two types of cancers. Let's say one is very slow growing, less fatal. And so graphically, you got this bar, and okay, fine. Time alive and cancer long. The other types are cancers that are quickly growing, highly fatal, so time alive is short. And so let's say you have 6 of one, half dozen the other. Over time, you sort them out. And let's say you do a surveillance or 2. All right, let's say you do it here and here. And guess what? When you do this example, conveniently example, 5 of these long slow-growing cancers, long survival time were detected. Only one of the fast-growing cancers are detected, all right? So if you look at the total population, you know, there's a certain survival time. But it appears that surveillance improves survival because basically you preferentially pick up those cancers that are slow-growing. And so that's just what happens with when you do surveillance. No matter what you do, you're always going to pick up things that are more likely to pick up, and the things you're more likely to pick up are things that are around longer, all right? So in the cases of different cancer biology, surveillance will always preferentially identify those patients who are more likely to survive. So defining cases as cancer detected by surveillance will make surveillance appear to improve mortality. And so this is what, one of those two was what we believe is going on. And if we have time in the discussion, I believe it's actually lead time bias was what we found. There's some statistical things that I've figured out at some point that I don't think there's long time bias. But the bottom line is that we don't know. And the question is, should we screen patients with GERD symptoms to decrease mortality from cancer? Obviously, as I suggested, what would answer this study would be a randomized controlled trial comparing screening and surveillance with no screening and surveillance. Difficult ethically, very long, very expensive. Can we get an idea now? And so this is kind of the second half of what I do in my research career. And hopefully by the end, I can somehow convince you that this is a viable research career and actually makes sense and potentially could make an impact, at least in immediate sense. It doesn't have long-term consequences, but I think in the immediate sense, you do get some ideas. I think from mostly, this is an aside, from decision analysis, it's difficult to tell you what to do. I can tell you what to think about as opposed to telling you what to do. And decision analysis is oftentimes a quantitative summary of existing data. It's a meta-analysis. It's like, you know, the answer to life, the universe, and everything is 42. I'm not sure you guys remember that, but that's what it is. You may not know what the question is, but here's the answer. It's also very good at hypothesis generation. But again, it's very difficult to say, this is what you do based on decision analysis. So having that, keep it in mind. I and a bunch of really smart co-investigators looked at this, gosh, about 10 years ago. We wanted to hypothetically look at a high-risk population being 50-year-old white males with GERD symptoms. Again, this is 10 years ago before we had a better understanding of risk. And we followed them to age 80 or death, and strategies included no screening or surveillance, or one-time screening looking for Barrett's. And doing what we do right now, which is surveillance for everybody with Barrett's esophagus, and then modeling something a little bit more novel, also something you couldn't do in real life. Remember, this is a hypothetical model. Usually at the end of the talk, they say, well, how'd you get 100,000 patients to enroll in the study? And I keep thinking, okay, these are 100,000 little bits that either are positive or minus, and they're little computer things. So this is all a computer simulation. I wanted to figure out where the bang for the buck is. Was it the initial screen, or was it the subsequent surveillance? And so I thought, well, heck, let's just look at screening and surveillance. But then people said, well, you can't just not survey people with dysplasia. You got to do something with them. So I said, okay, fine. Surveillance only with dysplasia. That's what we did. I'm going to maybe bore you with a few things, and then maybe this is mainly for some of the trainees who may want to know how we do these things. These are decision analyses and the computer simulations. The outcomes in this case are something called the incremental cost effectiveness, and specifically the cost per quality adjusted life year saved, kind of the bang for the buck. We took a third-party payer perspective, mainly CMS or Medicare. We use our transitions from big systematic reviews of literature, and we use Medicare as our cost basis. And so the Markov models are health state models. So you got states of no Barrett's, patients with Barrett's in low grade or high grade. You can develop cancer. You can be dead. You can be dead from many different things, cancer and otherwise. And you get surgery. And Markov models mean that you can have a state, and with every cycle, and every cycle means some time frame, let's say in this case a year. Every year you can, let's say, start with Barrett's and you can stay in Barrett's, or you can transition to Barrett's, no Barrett's, you can stay in that state of no Barrett's, you can transition to develop Barrett's, or you can die. In this case, you would die of things other than cancer. And then if you have Barrett's, you can stay in there, you can go on to low grade, you go to high grade, you can go back and forth between low grade, and you can also die. Everybody can die. And then you can get really messy, because when it gets to the point, it's a lot of arrows. And this is actually, the final ones end up getting close to 100 states, because this is what we know you have. What these models often do tell you, what you think you have. Meaning, when we do diagnoses and we do endoscopy with biopsies, we may get it wrong. We may say you just got Barrett's, but you may have Barrett's with low grade or Barrett's with high grade or Barrett's with cancer because you may miss something. So these are the states we have to build in the model, and we try to recreate life as much as possible. It sounds pretty presumptuous, doesn't it? Anyway, so a variety of assumptions. In this particular case, if you didn't have dysplasia, we modeled a couple of things. If you did have low grade, which is surveillance, high grade, we just modeled surveillance and esophagectomy. At that time, of course, we didn't have a model for treatment. We'll talk about how that went. But again, this is about 10 years ago. And these are the results. I think these are still holding true. What you have on the x-axis are qualities, quality-adjusted life years. And so you have to remember that when you do quality adjustments, let's say if you get cancer and you get a year of chemotherapy, that year undergoing chemotherapy probably is not as enjoyable as a year without having cancer and chemotherapy. So we have to adjust for that. The other thing is that they're discounted. Discounting means that money and every other outcome, including life, is more valued the more proximal it is to you in time. So something that happens 50 years from now, you don't really care about, money-wise and probably year-wise, life years. Whereas something that happens next year is very important to you, and we take that into account. And so you want lots of qualities and costs on the y-axis. You want as little as possible on those. So if you don't do anything, we just estimated there's a certain number of qualities and expenses associated with that. When you do screen, you don't save money. I think I want to point that out. We're not saving money. We're actually spending money. But you do spend money and you get some benefit, meaning an improvement in quality just life years. But that's mainly with the screen. You start to do surveillance of 5 or 4 or 3 or 2. What happens is that you really start piling up the costs, but we're not doing a whole lot to bending the curve in terms of benefit, all right? And in fact, the slope of the curve is the difference in costs over the difference in benefit. That's the incremental cost effectiveness ratio. Cost for quality just a life year. And so, as it turns out, this initial one, doing the initial screen, not so bad. Very much in line with what we do right now with colon cancer screening, breast cancer screening, cervical cancer screening, airbags in cars, dialysis, and all those things. But then once you start doing a lot of surveillance, that's really, really, really expensive. So not so smart. So what did we learn? Well, what is cost effective is screening high-risk groups, however we define them, for prevalent cancers, and surveillance basically only in the highest risk groups. What's not cost effective is a bunch of surveillance in low risk groups, all right? And why is this? Well, GERD symptoms we know don't detect all Barrett's. Barrett's is a poor marker for progression to cancer. In fact, again, we think that diagnosed Barrett's and people under surveillance seem to really not progress. And the weird thing is the incidence of cancer is lower than prevalence. This is gobbledygook. It's statistics. But the bottom line is this, is that the majority of patients who develop cancer really already have it by the time we find they have Barrett's. And it's a recurring theme. This is something I did, 10 years ago, and mathematically, we predicted this. And now, of course, I've shown you that the problem is that a couple things. One is that 40% of patients who develop cancer never report significant heartburn. This is empiric data. This particular one's from Sweden. And I think the biggest thing is we got to change the screening criteria as our latest guidelines reflects. Instead of just relying on, let's say, reflux symptoms, take into account age, sex, race, obesity, and hiatal hernia. And I don't have time to talk about it, but certainly a variety of my co-investigators are trying to develop a better prediction tool and try to change the focus of who we're screening. So I did tell you about the fact that we're changing the way we manage dysplasia, at least. Certainly 10 years ago, we only had options of either surveillance, which is watching, or esophagectomy, which is whacking out the esophagus, right? Now we have ablation, and I alluded to the fact there's radiofrequency ablation, photodynamic therapy, argon plasma coagulation, multipolar electrocoagulation. These are all kind of fun toys that we as endoscopists get to play with. Most of them involve playing their video game on our screen and then targeting something with little lasers and something flashing and a bunch of smoke going up and everybody clapping. All right? It's a lot of fun. And we feel very good about ourselves. But the question is, does ablation prevent cancer, right? So this is the first part. In fact, these are videos from both Juha Huang and Mike Saunders, who, of course, are fantastic faculty in my division. This is an endoscopic mucosal resection. This is the distal esophagus. And under narrowband imaging, you see this raised bump here at the very end. Well, that's what we believe in this case. This is an intramucosal carcinoma. Here, Juha is injecting the base with saline to kind of raise this up. Remember, the esophagus just has mucosa, and then there's this muscle layer, and beyond the muscle, there's no serosa. You just got like heart and lung, all right? So we're doing this. We raise it up, and then we have this band ligator, which is the same thing we use for banding varices. We suck this little lesion in there. We suck it in. We pop a band on it, all right? So now we've created a polyp out of something that wasn't a polyp, right? So, okay, perfect. So it's sitting up there. You can really see it pretty nicely. Then we put a snare loop, same thing you use for polypectomy. You stick it around this thing. Usually you grab it below the little band. You apply cautery, mainly to destroy tissue and make sure you don't bleed. And then you guillotine the thing off by snaring it off. You see a little bit of smoke. Not very much smoke. Okay, oop, there it is. And then you suck it in. And then you hope as you pull it out, you don't drop it into the trachea. And then you have this big hole. Near that big hole, you can see that kind of bluish stuff. That's just the muscle layer. And it's always very funny. So when, I'm sure you all know Dr. Carlos Pellegrini. Carlos and I, well, this is a funny thing. So I was a student at UCSF, and I remember holding retractors for Dr. Pellegrini in the OR when I was a student. He says, oh, of course I remember you, which is, no way. Because I was like a student holding retractors, right? But he comes into our endoscopy unit, and we're saying, gosh, we got this big thing we're going to take out. We're going to create like a big hole. He goes, oh, do not worry. Do your procedure, make your hole. If you perforate him, I will come in and save his life. And the best part is this is actually what he tells the patient, right? So, we're trying to do our work. We look like a goat, and here he is to save the day. Anyway, but I love Carlos. He's fantastic and a great partner. Is Carlos here? Is he? Anyway, so that's EMR. Now, once you take off all the lumps and bumps, then we do this radiofrequency ablation. And radiofrequency ablation is just another way to fry the tissue. This particular case is a woman that was referred to us with 10 centimeters of Barrett's. And it's all flat, but this is all pink tissue. There's a little bit of this gray stuff and a big hiatal hernia. Now, this RFA is basically a balloon catheter, and it has a double helix of electrodes. One is a positive, one's a negative. So it's a bipolar electrode, so there's no ground. And it basically just kind of applies current through this using tissue as a resistance, and then it causes heat, and then it fries stuff. But it fries it to a certain temperature, and we know that with a certain temperature, that we only ablate a couple millimeters of tissue. So we're not getting to the muscle layer, but we really are thinking that we get almost all the mucosa. And so this is just the first area, and these balloons, then you can, what we're doing right here is ablating this entire area. And then what we do is very, very scientifically, we kind of scrape it off, right? So whatever we did right there, that's now just kind of raw tissue. We're scraping off all the sloughed tissue, and we do it again. And this is basically it's a pre-programmed device. Nothing is idiot-proof, I must say. You can always do danger, but this is a pretty standard procedure that we can do successfully and safely. And that's radiofrequency ablation. And so the efficacy this is one of my friends, Nick Shaheen, who's been also on the guidelines that we're talking about. And he has this is a 2- and 3-year follow-up that was just published last year. And among patients who had intestinal metaplasia with high grade or low grade, complete eradication of intestinal metaplasia, meaning the non-neoplastic Barrett's, in year 2 and year 3, 93, 91%, looks really good. If you have high grade, you can get rid of the high grade in 95, 96% of the time. If you got low grade, it just doesn't come back. And so it looks really good, right? I mean, so this is great. But then I got a Nick's case because these rates allow for interim focal, he says, oh, touch up RFA. And so, the original protocol calls for, initial ablation using this balloon, and then 2 more, or at the most, total of 4 total sessions in that first year. And the problem is that, talk about safety first. It seems to be pretty safe. Compared to PDT, the stricture rate is not 25%, what we had with photodynamic therapy. It's closer to 7%. And and almost everything can be managed endoscopically. So I believe that. But the interesting thing about this trial, again, one little sentence in the results is that focal RFA retreatment had to be done in over half of the people after that first year. So they're continuing to come back, and they're continuing to use therapy. And that's how they got those big numbers. If you look at the actual numbers, when you don't have this, make kind of an intention to treat, you can see here that in the dark line, this is high-grade dysplasia, and the dotted line, it's low-grade dysplasia. And about 20% of the people have recurrence. They can get rid of it by doing repeated RFA. You can get, again, 20% of high-grade comes back, and about 10% of low-grade comes back. But if you define failure as recurrence, even if you don't retreat, then you actually have higher rates of recurrence. And so the problem with this is that it does recur, and it may not be an issue unless you develop neoplasia. And in fact, there is neoplasia. And the latest thing this year was that there was 3 reported cases of something bad, high-grade dysplasia, actually 2 esophageal adenocarcinomas. Now, these were small, and they're treated with esophagectomy, but this is a problem, right? And so I think the idea now is that RFA is not a cure. I feel like in many ways we're a little bit schnookered meaning even the industry says, gosh, this is a treatment and a cure for Barrett's. It really isn't. Well, we can say that recurrences are retreated, and you can get back to remission, and you can do it safely. But I think RFA really is chronic suppression therapy. It isn't a cure. It's a big difference. And you need continued endoscopic surveillance, and you need intermittent focal RFA for recurrences. And I think this is a major shift in the way we think about therapy. This is chronic therapy, not a one-time cure. And so one of the things that comes up is not only does it recur, but it recurs below the surface of the neosquamous epithelium. So squamous epithelium is what you like to see in the esophagus. Here, within lamina propria, this is a shot of buried metaplastic glands. So in other words, when we do this, sometimes you get neosquamatization. That's really not even a word, but you know what I mean, right? So once we do this, the squamous tissue comes back. Oh, yeah, once you put them on a PPI, acid suppression, no acid, you get the squamous tissue, and usually it's just kind of nice, gray, beautiful looking stuff. It's amazing how you can abuse the esophagus and it just kind of comes back. But below the surface, you can occasionally get these buried metaplastic glands. These are Barrett's glands. These are the things that you can actually turn into cancer. And in fact, we worry that all we've done with this Barrett's ablation is now we can't survey because we don't even know it occurs, right? And so the problem is that conventional endoscopy, either with white light or narrowband imaging, you can't detect it because it's below the surface. We worked a lot with confocal laser under microscopy, and it's a very cool technique that we do a lot down in our DDC, but the depth of penetration is only 50 to 100 microns. Is not good enough. So now we're working on optical coherence tomography, and OCT is actually a potential player in this. This is actually work from Juha Huang, who's both a PhD bioengineer as well as an MD and a therapeutic endoscopist. And here we see histologic photograph of, here's some squamous epithelium right here. These are squamous tissue. And here's a Barrett's gland kind of bursting through. If you do OCT on this thing, you can actually see this. The best thing is that the squamous epithelium is here, and you can see this adenoma down here that's, I was going to say, it looks hypoattenuated. It's attenuated or hypocoac. But the bottom line is that you can actually see subsquamous Barrett's. The other thing is I want to show is that you can actually see some structures as you go along. Remember this kind of picture. I think better is here. Here is a squamous epithelium after a ablation, but below here are these glands. These are the Barrett's glands. And you can imagine that, endoscopy, you can only see this, probably looks fine. You don't know this is here. But you throw on the OCT and you see the squamous epithelium, you see these glandular structures that in fact represent the Barrett's esophagus. And again, we're getting 500 microns or so, so much deeper than confocal. And here, in fact, is high-grade dysplasia, basically too much blue. That's all I know. When I do, like Melissa Upton and Matthew Ye and all of our friends in pathology, they thought. But besides this, the glands are very disordered. The reason it's too blue is it's got a lot of nuclei. They're piling up on each other, just really disordered. This is high-grade dysplasia. And in OCT, you get a lot of attenuation of any structure. You really can't see structures below the surface. So this is high-grade. And once you get to cancer, this is adenocarcinoma, then you really have complete attenuation. So you really could see these things on OCT. And they published their work, and we think that you can image substructures that are half a millimeter down. It takes about 12 seconds to acquire each image. So not only can you see below the surface, these are real time. All right, so this is kind of we call optical biopsy. We're being able to detect disease below the surface, but also detect the difference between normal as well as neoplastic tissue. I think it's a really promising tool for identifying metaplasia, dysplasia, and cancer. And it's stuff that's being done right here at UW. And so I'm going to kind of finish on one thing about reevaluating this. So I told you 12 years ago, or 10 years ago, I looked at this. A bunch of us got together, and I'll tell you about this collaboration and the NCI funding for this. We wanted to look at the cost effectiveness of ablation, not so much screening that I talked about before, but what do you do about ablation? So among people with Barrett's, what do you do? And it's Barrett's without dysplasia, low-grade dysplasia, or high-grade. We use all these updated data. They're really lousy, very low progression rates of cancer. We took into account subsquamous metaplasia and the fact that you can't survey for it and you can develop cancer. We also looked into the latest rates of recurrences and failures of ablation. And again, it's a computer simulation. And here's the results. I'm not going to give you anything of the results. Still, though, if you have high-grade dysplasia, it really appears that RFA dominates surveillance. Dominates, in this case, means that it's both less expensive and more beneficial. So really actually cost-saving to do this particular intervention, but only among patients with high-grade dysplasia. In other words, it's always better and cheaper to prevent cancer than to treat cancer. That's kind of the basic thing. Seems obvious, but I guess you need a model to do this, right? So low-grade dysplasia, RFA is cost-effective. It's really low-grade. The problem with low-grade is it looks a lot like inflammation. And you remember that Barrett's is oftentimes due to reflux, so we think it's all due to acid reflux. Whether it's symptomatic or not is a big question. But reflux is inflammation. So Barrett's is inflammation. So it gets very confusing between inflammation, reactive changes, and low-grade dysplasia. But if you find that you have a diagnosis of low-grade that's multifocal, multiple sites in the esophagus, and it's stable over time, meaning you watch a patient and it's there 6 months later, 12 months later, then it appears that it's real dysplasia, then RFA appears to be cost-effective. What is not cost-effective is doing RFA in patients without dysplasia. And the problem in the US is that, of course, it's FDA approved. The vast majority of people in whom RFA is done are people without dysplasia. And I think that's wrong. And I think it's, at this point, it's optimal to continue surveillance and doing RFA for either persistent, confirmed low-grade dysplasia or high-grade dysplasia. And I think that's basically where we go. So the summary of ablation, this is the ablation part, I think we now realize that ablation is not perfect. I think many of the problems are recurrences are common. I think that we know that you can do repeated ablation and it seems to be safe and effective, but really RFA is suppression. It's not cure. And I think we have to change the way we think about RFA or endoscopic therapy. I think subsquamous metaplasia is a real problem because by our usual surveillance techniques, we can't even see it. We don't even know it exists. And I think that it appears to have been more common after other endoscopic therapies. I didn't talk about photodynamic therapy or MPEC or APC. Those are other types of endoscopic therapies. And it appears that RFA is better than those, meaning that you have less recurrences and less subsquamous metaplasia, but it is something that occurs. And we need better tools to look at this. And I'll hopefully kind of make a plug for that in the next slide. But even with these problems, ablation appears to be still cost-effective compared to what we're comparing it to, which is surveillance, which of course is not very good. So when the bar is pretty low, you can come in kind of medium and get the job done. But certainly for at this point, all high-grade dysplasia, what I call real low-grade dysplasia, but not for non-dysplastic tissue. So I think the future is the following, and this is where I want to spend a little bit of time. I think the big thing is improving detection of Barrett's. I think we know Barrett's is going up. We know that esophageal adenocarcinoma is going up. We're just not doing a good job of understanding who has Barrett's. And I think that the big thing is doing a variety of things. There are a variety of demographic, epidemiological, and those kinds of things that we can ask patients to stratify patients. But once we have patients who we think have Barrett's, we're doing endoscopy, we need better tools. So one of the things we're working on are molecular probes. I'm in one of these groups, BetterNet, and the BetterNet is the Barrett's Esophagus Translational Research Network. And I'm bringing it up twice here because there's 2 of these groups. 3 groups were funded throughout the country. This is a U54 mechanism. And 2 of the groups actually have PIs that are here at UW. So it's a huge thing. The group that I'm not a PI, but I'm a co-investigator working with Eric Seibel here, as well as Tom Wang and Dave Beer at Michigan. We're looking on molecular probes that are that really do recognize these receptors that are expressed in the surface neoplastic cells. And we're using, at least Tom is using these peptides that are coupled to these fluorescent beacons. The thing we're doing here at UW is that Eric Seibel is a bioengineer, and he's got this really cool single fiber scanning endoscope. And so, you think, well, gosh, these days we're using these CCD chips in our scopes. Well, and fiber optic technology is kind of old-fashioned. But these fiber optics, he's using 1 fiber, which of course is like the size of your hair, right? And that's your endoscope. So you get the thing the size of your hair, and what he does is makes it spin in like little concentric little spirals. And by doing that and recreating it, he can actually get all the pixels done and recreate it. So you can get a huge picture with 1 fiber as it spins around, right? So it's really cool technology. And again, it's the size of a hair. The problem is that, we can't even swallow this thing from the side of a hair, so we got to put something bigger so you can swallow it. That's how small this thing is. So we are doing a bunch of work to perfect this particular device. And we don't even, in many ways, we don't even have to have an image that looks like real life. Why bother? All we got to do is look at these fluorescent probes. And that's pretty simple because it says, I'm red, I'm green, I'm blue. These are what I'm looking for. We don't need a whole lot. So it's exciting to really be able to develop this kind of translational work that will really hopefully be able to not just look at a better way of screening, but a better way of surveillance. Bill Grady is a PI of another BetterNet group. This is, I would call it a biomarker group. It's a group that's very interested in understanding early detection, risk stratification among those patients who are detected, and then tailored therapy. If you have a diagnosis of your cancer or high grade, what are the markers that indicate what kind of therapy you want to get? And this is very exciting stuff. There's a 3rd group that are working on mouse models, and I must say, I don't know what the heck they're doing. I like the mouse models, but the problem is that the mouse models I have don't look anything like Barrett's, and they don't look like they mimic real life. And in fact, what they're doing right now is they're saying, look, if the mouse model shows this, it doesn't correlate what we see in the human, so our model of the human must be wrong. And I'm saying, wait, no. It means that, oh, never mind. So we're there, we're getting there, but it's a fascinating group, and I really hope that we're going to do a lot in the future. So here's my second last slide. This is my clinical messages. So screening right now, we're basing things on heartburn. I think in the future, and we're really trying to push this, we just don't have very good data to know exactly how to do this, but age, race, sex, for the male, obesity, hiatal hernia, and heartburn. I think in the future, combinations of these are going to be what we're going to do to trigger screening. Surveillance, again, low effectiveness to reduce mortality, but it may just be because the fact that we're screening the wrong people, and surveillance basically is being conducted in an already low-risk group. At this point, endoscopic therapy, again, the idea is better to prevent cancer than to treat cancer, and certainly high-grade dysplasia and real, as I say, real low-grade dysplasia deserves therapy, but really not non-dysplastic Barrett's at this point. In the future, advanced imaging, hopefully you'll stay tuned, and in a couple of years I'll tell you what we're doing here. Molecular diagnostics, I think these are just really key. And then chemoprevention, because I said, well, gosh, you want to prevent cancer. If we could find the kinds of criteria that detect or high-risk people, and then you do something that's like a single fiber endoscopy to diagnose Barrett's, and then only find those patients with Barrett's who are destined to get cancer, and you throw on something like an aspirin maybe, or something better to prevent cancer, then maybe we won't have to do endoscopy at all, which is hard to believe coming from an endoscopist, that we may not have to do endoscopy at all. And so my last slide is really my acknowledgements. I talked a little bit about the BetterNet, and again, the folks I'm working with are the people in Michigan and here at UW and imaging. Bill Grady, Amitabh Chak, and Ken Wang, or the biomarker group. University of Michigan. Joel Rubenstein's been a wonderful collaborator. And the CISNET, which I want to make a big plug for. CISNET is the Cancer Intervention and Surveillance Modeling Network. I guess we are the bunch of pointy heads. So, mainly epidemiologists, biostatisticians, mathematicians. I work with a great group of people in Erasmus University in Rotterdam. Marjolein van Biagoyen. That's a mouthful. It took me 2 years to pronounce that. Sonja Kruip, Iris Landorp. They're fantastic people who are basically epidemiologists and biostatisticians who are doing great work in understanding how to model these diseases. Mass General, Chin Her, and the Fred Hutch, who's another part of our group. Gerard Lubeck, if you don't know him, a fantastic guy. He's, again, in their PHS division. Kit Curtius, JJ Gian, and Bill Hazelton. These are fantastic co-workers, and I really enjoy working with them. So hopefully, give me an idea of what to do clinically. Hopefully, I've given you an idea what to think about, and maybe in a couple of years, I'll have a better answer.